Good
All right.
morning. Yep, go ahead, Mike. I'll
No,
just
no,
let
no.
you.
Go ahead. Go ahead.
Yeah, I was just going to quick introduce you. My name is Tammy Garcia. I am the Senior VP of Sales and Marketing for Seno Medical. Thank you, everyone, for joining us this morning. I know it's early in some parts of the U.S. and nice morning in others. But we are thrilled that you're here to join us and hear about this exciting new modality, really, for breast cancer diagnosis that was just FDA approved. Dr. Mike Ulissey will be sharing some information around it. And at the end of the session or throughout the session, please feel free to ask any questions so that we may answer them at the end. Go ahead, Mike.
Well, thank you very much. I'd like to thank Tammy, Seno Medical, and of course, Christine in the NCBC and all of you for attending the session. Just kind of wild doing these all on Zoom now, all the talks at the med school and all the lectures and things like that. But anyway, life before COVID, life after. Thank you for being here. So today we're going to talk about an introduction to optoacoustic imaging. It's a new technology recently approved by the FDA that is used to help analyze breast masses. And I'll go into more detail with that in just a second. I am retired from UT Southwestern. I used to be director of breast imaging out there in Dallas, Texas. Retired professor from UT. I still stay on the adjunct faculty for teaching and research and things like that. But I've also had my hat in private practice over the decades, and most recently in the why is this not going forward? Most recently in the Seattle area, 2-bedroom communities of Seattle, Auburn, and Federal Way, where since late 2011, I have co-owned a couple of breast imaging centers. We recently formed an association with Center for Diagnostic Imaging, and it's been really fantastic. So I come up here. I'm in Seattle now. I'll be seeing patients about 8 o'clock. I come up here 1 to 2 weeks a month to help cover vacations and see patients. And the rest of the time, I'm semi-retired to Sedona, Arizona. And I have a big telescope. I love astronomy. Anyway, I'd like to thank Tom Stavros, Lee Tucker. Tom, I think you guys all know one of the Olympic gods of breast imaging. Lee Tucker is a pathologist near the DC area, does a lot of, helped us with all of the pathology for these various studies, the histopathology, large section gross, large section histopathology. And Bruce Porter, I think you know him from the breast MRI days with the ACR and teaching and whatnot. And he has helped give some very good contributions to this talk. I am a consultant for Seno Medical Instruments, full disclosure, and what I'm going to talk about today. So first of all, what is optoacoustic imaging and what was the rationale for developing? Why do we need a new technology? How is it going to help us? It is a laser-based technology, and so I'll talk about how the lasers are fused with ultrasound to give us both functional and structural imaging of a breast mass. And I will discuss how it differs from Doppler. It's a new, independent, totally different, separate technology. This is not like an ultrasound add-on like Doppler or something like that, or elastography. It's independent technology, actually processed by a separate set of transmitters, receivers, and computer systems. So I'll discuss how it differs, and then we'll talk about some of the OA features that allow us to accurately identify a mass, such as not just the internal zone of a tumor nidus or any kind of mass, fibroadenoma, but the external findings as well, the findings right on the boundary zone, the capsular and boundary zone, and the peripheral zone findings. And then we'll go into a little more detail of what of the displays that OA gives us, and how it gives us both functional and morphological imaging. So why do we need a new technology? Well, there are a couple of, we get dinged a lot by not only our clinical colleagues in family practice, primary care. Oh, you do too many biopsies. You have too, and most of the biopsies turn out to be benign, and you do all these unnecessary biopsies. And I have to admit, there's a lot of fibroadenomas out there I wish I didn't have to biopsy, and that's where OA can really help us. But an unnecessary biopsy sometimes to me is something that happens on somebody else, not on you. Because if somebody tells you you've got a breast lump and they're a little bit worried about it, you want to find out what's going on. And if you can obviate the need for a biopsy and have a good piece of technology that allows you to do that, fine. And that's what OA is really going toward. The thing about breast imaging, though, we're really good in sensitivity. We can pick things up, BI-RADS 3, even 98%. Some things BI-RADS 2, we're probably 0.5% at it being benign. But it comes at the expense of specificity. Remember, if you have a medical test, for the most part, there are very few tests where you can increase the sensitivity and increase the specificity. In most cases, if you're going to increase the sensitivity, you have to give up specificity, or if you want to increase the specificity, you have to give up sensitivity. Well, in our goal of developing optoacoustic imaging, well, I say in Seno's goal, I was a consultant, but wasn't really any of the lead people. But anyway, they wanted to come up with a test that would increase our specificity significantly, but not sacrifice our sensitivity. And that's hard to do, which is probably why it took 10 years to develop the technology, but it's cool stuff. So what the goal of optoacoustic imaging is to accurately downgrade some of these BI-RADS 3 and 4 masses, generally the 4A category masses, those things out there that I'm pretty sure this is a fibroadenoma, but something a little irregular about the margins maybe, or the little heterogeneous echo texture or something like that I need to do a biopsy. And it's true. Most of the biopsies we do are benign, and there could be a lot of biopsies out there that we wouldn't have to do. We could accurately downgrade from a 3 to a 2 or a 4A to a 3, or a couple of readers in our studies were able to downgrade a few 4As to 2s. So anyway, so we want to reduce the number of benign biopsies, and we want to occasionally upgrade probably benign findings. We had a couple, I know of 2 in the studies that we did, where they were initially assessed as a BI-RADS 3. And when the readers looked at the optoacoustic information, they said to themselves, we need to do a biopsy on this one. It's not a 3, and they were right. So we want to do all this without sacrificing sensitivity. The basic concepts of optoacoustic is that it will give us functional imaging and morphologic imaging at the same time. Okay, now it will also be able to do this without administering ionizing radiation and without administering IV contrast. The theory behind, well, the way it works is that we know that cancers are more metabolically active, okay? They're functionally more active, and they have to extract more substrates from their environment. And their environment is the surrounding breast tissue and the arteries that feed that surrounding breast tissue and ultimately end up feeding the cancer. So they're more metabolically active, not only in substrates that they extract, but in the amount of oxygen they use. They have to churn and burn and use more oxygen than normal tissue and more oxygen than benign tissue. And because of that, they deoxygenate, and you get more deoxyhemoglobin. So optoacoustics demonstrates the greater deoxygenation that occurs not only in the malignancy, but near the malignant lesion as well. And that's really important, which we're going to talk about here in a second. But before I do, let me just show you, so this is an ultrasound image, and this actually, I believe, turned out to be a benign fibroadenoma. And then when you engage the optoacoustic imaging part of this, it shows you not only the central tumor nidus, but it shows you how the blood vessels are approaching this lesion as well. We'll go into more detail in a second. So it's basically dual fusion, where we have laser light in and sound out. Now, let me first back up one little step. Let's say, because I told you the goal of this was to help downgrade some lesions and obviate the need for biopsies. Let's say that you had a breast lump, and on every breast lump, you could do something like a PET CT. Okay, the PET gives you structural information. The PET gives you functional information, and the CT gives you structural information about a lesion. And that's married together. Those are fused technologies. So let's say you could do a PET CT on every breast lump, and after a while, you notice that these lumps that looked benign morphologically had no PET activity. Now, you can't, because PET's a super amount of radiation. You can only use it if you got a cancer diagnosis, but let's say you could. If after you did 200, 500, 2,000 of these analyses with a PET CT, and it had benign morphological features, and it had no PET activity or benign PET activity, after a while, you'd say, you know what, I've looked at 500 or 1,000 of these. They never turned out to be cancer. You would become comfortable, I think, at downgrading those. Well, that's what we're talking about here with optoacoustic imaging. The initial image, the initial functional part of the image, though, instead of using ionizing radiation, uses laser technology. So you have dual energy lasers that pulsate into through breast tissue, and they hit a mass, and then coming back will be an ultrasound wave that is registered by the OA device. This will also be fused with standard general medical diagnostic medical imaging ultrasound. So you will get the morphology from grayscale ultrasound. You'll also get some morphology from the tumor neoangiogenesis around a lesion from the OA, and then you'll get the functional imaging from the OA by demonstrating the amount of oxyhemoglobin versus deoxyhemoglobin, because again, cancer is being more metabolically active. They're going to churn and burn a little bit more, and they're going to be consuming more oxygen and having predominantly deoxyhemoglobin in there, in the area in and around the lesion. And that's what optoacoustics can show us. So basically a 4-step process. Brief pulses of 2 wavelengths of low energy laser are sent to the breast via an optoacoustic probe that looks exactly like an ultrasound probe. And it's actually a little bit thicker because it's got the optoacoustics built into the regular grayscale ultrasound. So that laser light goes in, and hemoglobin absorbs a laser light, and it causes a little thermoelastic expansion of blood. And because of that, it sends back an ultrasound wave. That's not the same ultrasound wave that you're thinking of in a regular ultrasound, 12 megahertz, 15 megahertz, 10 megahertz, stuff like that. This is largely a kilohertz ultrasound wave, but it's still an ultrasound wave that goes back to the transducer. And the transducer then has electronics, excuse me, electronics to receive the return signal that is sent to the OA computer for processing. But the signals that go out are not only the dual energy laser signals, but they're also the ultrasound, the regular standard medical ultrasound. So you have an ultrasound transducer, and this is probably not to scale here, but you have an ultrasound transducer right over here, and next to it, it's a little bit thicker. You hold it in your hand down over here. It's just a little bit thicker than a regular ultrasound transducer. And it's got 2 windows on each side for the dual energy lasers. Dual energy laser fires out of that one, dual energy laser fires out of that one, and ultrasound fires out of that one, and then is also received back to this one. The machine, if you look over here on the right side, is it looks like a regular ultrasound machine, and in fact, it is a regular ultrasound machine. If you look on the side, there are a couple of little handles here or spots for probes. This probe is the OA probe. You can see the little blue thing on the end of it over here. And this is a regular ultrasound probe. The machine can be used as a regular ultrasound machine, so you don't have to take the patient to a separate room to do optoacoustic imaging. When this screen, look in the upper left over here, you can see the ultrasound part of this. Initially, this whole screen is just ultrasound. And the GUI here, the graphics user interface, it's a regular ultrasound machine, and it has all the bells and whistles of regular ultrasound on it. And then you push a foot pedal. We're going to go down to the lower left over here. We're going to push this foot pedal after you look at something with ultrasound and you say, I wonder if this is functionally active, and you want to engage the OA. You then just push this foot pedal, and it goes from a single ultrasound screen to this 6-on-1 screen that shows you the regular grayscale ultrasound, but also co-registers the optoacoustic information. So you can do that right there at the same time that you're doing your regular ultrasound. And there might be a lot of lesions that you don't even need to do OA on. You can just use it as an ultrasound machine. Again, it's got all the bells and whistles that regular ultrasound has, and it's high quality ultrasound. So getting back into the OA technology, two wavelengths. There's a short wavelength and a long. You don't need to remember the details, but the rationale for picking the short wavelength was over here, and this is going to predominantly display deoxyhemoglobin, okay? This kind of maroon graph over here. So they picked it because this has a peak of deoxyhemoglobin, and it also has a pretty wide separation between the oxyhemoglobin over here, this reddish pinkish graph. So it also, the other important point is that there's a big separation, not only between the deoxyhemoglobin and the oxyhemoglobin, but also the deoxyhemoglobin and the water, okay? Because water, breasts have a lot of water, it tends to give us a fair amount of artifact, and so we wanted this a big separation there. Now, the oxyhemoglobin wavelength, notice it's not picked because it's the high part of the curve of oxyhemoglobin, but it's still it's a bigger separation of oxy and deoxyhemoglobin, and also a reasonable separation of water peak. So that's it. Dual energy laser goes in, and sound comes out, ultrasound comes out, kilohertz ultrasound. All right, now we could have married this to, or co-registered it with a lot of different imaging technologies. Could have been MRI, could have been CT. Why did we pick ultrasound? You know, variety of reasons. First of all, not only is it no IV contrast or ionizing radiation that's needed, but ultrasound has really good spatial resolution, and it's ubiquitous. I mean, if there's a mammo tower, there's an ultrasound in pretty much every breast center. I mean, unless you've got a screening center, you've kind of got a hub and spoke remote screening center, it's just got a mammo tower. But any diagnostic facility that does diagnostic mammograms has an ultrasound machine sitting right next to it. And it's easy for the breast imagers to make the translation and the transition from looking at standard ultrasound using Doppler and having an idea of what's going on, to make the transition to optoacoustic imaging. So that's why we picked ultrasound for that. Again, ubiquitous and easy to make the trade, and no IV radiation, no ionizing. No IV contrast, no ionizing radiation. Now, you know, the cancers. So when they first start growing, obviously starts off as a somatic mutation. Initially, as they grow, they get their energy, they get their food from diffusion, okay, down over here. All of this happens to be to come from diffusion, but after a while, when it gets a little bigger and a little bigger and a little bigger, it can't get the substrates from diffusion anymore. It has to recruit blood vessels to give it enough metabolic substrates for energy to continue to grow. And that is where it starts to do neoangiogenesis. And as it gets bigger and bigger and bigger, the angioneogenesis becomes sometimes a tangled mess all around the area of the tumor. And you can see where it gets recruited from the native blood vessels. This is the kind of stuff, interestingly, that you will see in a second that Doppler doesn't show, that OA does show, and why the boundary zones, the tissues around the central tumor nidus, are extremely important. Now, if we look at other, functional and structural imaging technologies, MRI is, one of the first that comes to mind. And it's a great study. I love breast MRI. It gives us structural and functional information, and it also involves contrast administration. Not only that, it's an expensive, complicated study, and you don't have breast MRI in every, breast center in the United States or every diagnostic mammogram center. You generally need specialty centers, and breast MRI, I don't know, it's a different animal. You need a specialist reading it, someone who's really specialized in breast imaging, because the first 1,000 studies are the hardest. BSGI, ionizing radiation, PET, PEM, not only injection of ionizing radionucleotide, but it's really a high radiation dose, and you can only use PET or PEM anyway, once you have a diagnosis of cancer. And then contrast enhanced digital mammography, it's injection of contrast followed by additional radiation. So again, some of the rationale of comparing OA and why we married it to ultrasound, and then the advantages of not using ionizing radiation or IV contrast. So again, you've got your OA probe. It's going to send in an ultrasound signal, a regular diagnostic medical ultrasound signal, and then it's going to send in not only the ultrasound, you saw 3 little pulses there, right? 3 little pulses, 1, 2, 3. You had the dual energy laser and you had the regular ultrasound. Now, what this will come out with is when it sends a signal back, is malignant will have relatively more deoxyhemoglobin, and benign lesions, because they're not metabolically active, will have relatively more oxyhemoglobin. That was our initial thinking, and it is true. Okay, so generally we thought, well, green is good, red is bad. Okay, and these were color coded, I guess, off the stoplight theory of stop and go. However, it turned out to be really grossly oversimplified, a gross oversimplification, because it wasn't just the internal components of the oxyhemoglobin and deoxyhemoglobin, but we learned so much more. Again, we thought initial thinking, green is good, red is bad. However, then we saw this lesion over here, which turned out to be a fibroadenoma. But when we put the OA on it, we thought, oh man, look at all of the red over here. And it did turn out, so we had to biopsy it. And well, in the studies, we biopsied everything anyway, or followed them for a year. But it turned out that that with the large section histopathology, this ended up it was a benign fibroadenoma in all respects, but it just happened to be one that had a ton of microvasculature associated with it. And because of it, it must have been deoxygenating enough blood to give it predominantly deoxyhemoglobin instead of oxyhemoglobin. So that's where we said, you know what, there's got to be something else going into this. And what we learned were that there were internal findings and external findings. And the way we learned it was from Bruce Porter. So he had come to the Seno shop and we were going over these cases and talking about this. And he goes, you know what, let me show you this case from Japan. And it's a contrast enhanced ultrasound that he had. And I want you to look at the middle of the screen right over here where my pointer's wiggling around, okay? And he said, let me show you what happens with contrast enhanced ultrasound on a cancer. So you're going to see the feeding artery coming in. Now it's coming into the central tumor nidus. All of this is feeding, and then all of this is draining out over here. So what you end up having, he said, look, you've got a central tumor nidus, but look at how these blood vessels are coming into the periphery of this lesion, how they're approaching this lesion that's a cancer, as opposed to how blood vessels might approach a lesion that's benign. We said, you know what, not only do you have a central tumor nidus, but there's a boundary zone over here, which is maybe just a couple of millimeters around it. And then there's a peripheral zone. And we found out that it was probably more important to look at what's in the boundary zone and the peripheral zone, initially anyway, than what's in the central tumor nidus. And interestingly, now I read all my regular ultrasounds completely different. I read from the outside in. The first thing I look at, when you have regular ultrasound, and I know the ACR says it's not important, but I think it's the most important. You have that hyperechoic, that thick hyperechoic rim around a cancer. That's where all the activity is. That's where the cancer is interacting with the tissue in the neighborhood. And that's why that zone actually, to me, is the more important zone, because functionally, that's going to tell you where all the action is. And then, of course, on the outside, the peripheral zone is going to show you the recruitment of these vessels, of the neoangiogenesis. So you can't rely on, we found out that you couldn't rely on just the internal information, went back and looked at all these OA cases again and said, let's look at the boundary zone and the peripheral zone. And most importantly, how are the blood vessels approaching the lesion? Because if you think of a fibroadenoma, when a fibroadenoma grows, okay, Starts off as a little dot, gets bigger and bigger and bigger. Because it's not cancer, all it's doing as it's growing is it's pushing the surrounding structures out of the way. And that's why it looks like tissues fold over or drape under a fibroadenoma, or drape over, fold under a fibroadenoma. It's going to do the same thing with the blood vessels. All it's going to do is it's not recruiting new blood vessels and making a tangled mess of angioneogenesis that's coming at the lesion in a haphazard way, 90-degree angles, but it's going to just push these blood vessels gently out of the way. So the blood vessels also will drape over or fold under the lesion. And that's what you're going to find in the boundary zone and the peripheral zone. And so we found that, or, going back and looking at this, Tom actually started coming up and he said, you know what, I got a bunch of different categories that are largely objective categories. Now there's some subjectivity. Is this got a lot of activity or a little bit of activity? But, he came up with these feature scorings that we could put into, and we could kind of come up and subjectively come up with different types of scoring categories, 0 to 5, or in some cases 0 to 6, that talked about reference keys. So in the reference keys, we could code the reference keys to say 0 is favorable, 5 is not favorable. In this case, one of the reference keys is total hemoglobin. You can also have boundary zone whiskers, peripheral zone vessels. What do the peripheral zone and boundary zone vessels look like? Are they smooth vessels that would indicate benign features? Are they nodular vessels that would indicate angioneogenesis? I don't want to go into the weeds on this, but there are multiple different reference keys associated with the central tumor nidus, with the boundary zone, and with the peripheral zone that you can subjectively score 1 through 6, 1 through 5, and come up with a scoring system that says, hey, this has overall benign features. Now, this sounds complicated, which is why I don't want to get into the weeds, but think about it from this standpoint. When you first started doing ultrasound, whether it was regular ultrasound or breast ultrasound, but in breast ultrasound and in breast mammography, when you looked at a mammogram and you saw a mass, you looked at an ultrasound and you saw a mass, when you were a resident, when you were in your first week on rotation, second week, third week, first month on rotation, second month on rotation, you had to go down and you had to pigeonhole these categories. And you had to actually, almost like a check mark box, say, this is circumscribed, this is hypoechoic, this is hyperechoic, this is heterogeneous. You came up with all these little check boxes to come up and decide whether something is it taller than wide or wider than tall, to see if all of these features lumped together indicated something was benign or something might be malignant. Well, you don't do that anymore, right? After you've done a bunch of cases, you do all of that in the back of your brain in maybe half a second. And as soon as you put the transducer on it, you can look and do all of this feature calculation, and you look at the mammogram and you correlate the mammogram with the ultrasound, and boom, in half a second, you have an idea of whether you're worried or not. Well, that's what's going to happen after you read a bunch of OA. Initially, you'll be pigeonholing a lot of this stuff, and you'll be coming up with little check boxes of whether this is favorable or not favorable and adding them up. But after a while, you'll just do it in the back of your mind, and it'll take you a second or two. And so anyway, the classic features. The other thing that I found that I have been able to do, and again, let me back up one. This is fibroadenoma. Look at how this blood vessel is just folding under this benign appearing lesion. This blood vessel is not approaching it in a aggressive way, but look at these blood vessels here at number 5. Look at how these little blood vessels are coming in at 90-degree angles. And this one coming in as a very thick nodular set of vessels. Same thing over here, this tumor blush. So the boundary zone, the peripheral zone, and the capsule here, this going right under the capsule on a benign fibroadenoma. Okay, so the other thing I found is classic features. After reading a few hundred OA studies, I was like, you know what? I can pretty much tell you whether this is going to be a grade 1, a grade 2, or a grade 3 finding, because there are classic OA features. Grade 1 findings are generally external findings, almost no internal findings. Most of it is right at the boundary zone and the peripheral zone. You'll see a feeding artery vein, and then you'll see a bunch of blush or whiskers right at the boundary zone. And you're like, and no internal features. And almost every time that's a grade 1. A grade 3, if we go to the opposite end, has almost all internal findings, and we don't really see external boundary zone or peripheral zone findings. And then grade 2 is a mix of the two. And almost every time now when I look at it, I'm like, wow, it turns out. So again, OA can demonstrate findings in all 3 zones. You have a central tumor nidus that you're seeing on regular ultrasound, and immediately it's co-registered with the OA features, and you can look at the boundary zone, this blush over here, and the way the blood vessels are approaching this lesion over here. And really, these 3 over here are the main ones that you end up using. I'll talk about what all these 6-on-1 mean in just a minute, but the 3 most ones that you'll use are in this corner right over here. Now, these boundary zone whiskers that I tell you about in the peripheral zone, this is the tangled mess of a central tumor nidus, and then the boundary zone, and out here is the peripheral zone. Look at the recruitment of these vessels, how they're nodular. That's why they look nodular. They're all kind of corkscrewed. Here they come in now. OA, it has resolution limits as well. It's actually better than Doppler, but it does have resolution limits. So it might take these thicker blood vessels and be able to resolve them as individual vessels. But when you get to the small vessels, like up over here and these vessels over here, a lot of times it can't resolve them as individual vessels. So it volume averages them into a blush. So you'll get a blush over here, or you might get little whiskers like these things over here might be little boundary zone whiskers. And then these might be individual vessels that can be resolved. Same thing over here. So you have your central tumor nidus, and these things, OA probably cannot resolve the individual vessels. So it creates a whiskers or a blush. Now, why do I say it's separate technology? It's not like Doppler or an ultrasound add-on. Think about the times that you actually engage Doppler. You know this thing is a cancer. You put the Doppler on, and it's got almost no activity or very little activity. That happens all the time. Most of the time now, I use Doppler just to find out where I'm going to do my biopsy on the mass. I don't want to, if there's a lot of blood activity in one area, I don't want to turn into a gooey mess, so I'll stay away from that area. But there are so many times, see, Doppler requires the movement of blood, okay? It's either moving toward the transducer or away from the transducer, and it doesn't have as good resolution, resolution as ultrasound. So you'll engage Doppler, and you'll see no activity, and you're like, man, I know that's a cancer. You'll see no activity on it, but OA shows the presence of blood. It's not movement of blood, it's the presence. And is the presence predominantly oxyhemoglobin or predominantly deoxyhemoglobin? And that makes a big difference. And that's why, again, it's a separate technology that's married to ultrasound, processed in different computer systems, different computer algorithms, and just co-registered and displayed together so that you can get structural information from the regular ultrasound and then functional information from the optoacoustics information that you get. So again, Doppler, you know that this is a cancer. It's got almost no or a couple little ditzels of Doppler activity. OA, look at how these blood vessels are approaching the lesion. I'm not saying that you need OA to decide whether you're going to do a biopsy on this or not. You're not. You're going to do a biopsy on this. But understand what cancers look like with OA so that you can see when something's benign and be confident over time. There'll be people who adopt it more slowly than other people or quicker than other people. But over time, you'll understand, hey, this is the difference between malignant features functionally and the difference between malignant features or benign features functionally. So let's look at a couple of benign findings. Again, you're going to have something that structurally looks like it's oval, it's wider than it is tall, but not only that, the blood vessels on this one over here are approaching this lesion and they're just draping over. There's nothing aggressive. And I'm going to talk about the artifact that comes up. Same thing here. This blood vessel, even though it's a draining vein, it is a blood vessel that's approaching this in a non-aggressive fashion. When this fibroadenoma started growing, all it did is it pushed the surrounding tissues and surrounding blood vessels out of the way. It didn't recruit any and cause angioneogenesis. Okay, same thing here. Now, this doesn't have a lot of peripheral zone activity, but it's all green on the inside, predominantly oxyhemoglobin, and it also has benign features sonographically. So if OA needs to be effective, it needs to be effective in small screening detected masses to have maximum benefit. And it is. We have tested it on 8 millimeter grade 3 invasive ductal. Actually, this, I believe, was from one of the studies that was initially thought that it could be a BI-RADS3 incidental finding. Maybe it was a baseline mammogram, but when they engaged the OA, there was like a ton of OA activity, not only in the central tumor nidus, but in the boundary zone. And I believe this turned out to be a triple negative. Yeah, triple negative breast cancer, right? But it shows you the boundary zone and central tumor nidus. And in this case, it was used as an upgrade. Okay, this is a little tiny 3 millimeter, 3.5 millimeter grade 1, but look at the recruitment of vessels and look at how these blood vessels are approaching this lesion in an aggressive way. And really, I think it extends down into here as well. But tumor blush certainly around there. And there you go, boundary zone, peripheral zone. So when you're doing your sweeps, the point is that when you're doing you're using this as the same way you would an ultrasound probe, and it's married at the same time. But what you want to do is make sure that when you do your sweep, you're not, the sonotech brings you an image, and he or she just brings you a static image of maybe the center of it this way, and then turns 90 degrees and gets the center of the mass the other direction. But when you do OA sweeps, and even when you do ultrasound sweeps, you've got to start from the outsides, from before, because you want to see this angioneogenesis. Okay, you don't want to just see what's happening in the center of this and on the initial boundary zone on one slice this way, and then an orthogonal slice the other way. You want to be able to see the angioneogenesis, and a lot of times it happens farther away than you think. Okay, so make sure you sweep. You might even do it a little bit longer, a little bit farther sweep, and go, all the way back into here and all the way back over to there. So the important thing is you can't just look at the tumor lump. You've got to look at the blood vessels and the surrounding tissue. Sometimes, again, quite a ways out. Okay. So the video sweeps, you have to include surrounding tissues. All right, another grade 3, I'm sorry, this was a grade 2. So it's got external features and internal features. Okay, and this might be shadowing. This might be part of again, you can see the blush over here, the tumor. So it might be even a little bit bigger, but look at the peripheral zone and look at the way these vessels are approaching this malignant lesion. All right, benign fibroadenoma. Here you go. You've got the central tumor nidus. It's not a cancerous tumor, but it's a growth. But look, this is approaching it, and this is a static image. You use your video sweeps, and you can see that this is nice and smoothly going along the capsular, the boundary zone of the capsule over here. And there's nothing aggressive about the internal features, and nothing aggressive about the way the blood vessels are approaching it. And you can very successfully, we've been able to, I'll show you the data and the results. But so what do the 6-on-1 displays show? Okay. Initially, so the first thing that comes out is the grayscale ultrasound. Okay. You get regular ultrasound, then you push the button and it switches to the 6-on-1 windows. And in the 6-on-1 windows, it shows you the ultrasound, but it also shows you all the other information. We were thinking initially about not including it, but all the researchers said, yeah, we want to put in the raw data. These two on the far right over here are the raw data, okay? The short wavelength and the long wavelength. Whoops, sorry about that. I hit the button too fast. What'd I do? Okay. So you've got the short wave data, the long wave data, And these basically show you the predominance of deoxyhemoglobin and predominance of oxyhemoglobin. And from there, the engineers can combine the short and long wavelength, and they can figure out two things. What is the relative amount of oxy to deoxy or deoxy to oxy? And then where is the total amount of blood? Now you can see all of this stuff here on the periphery. Everything I'm pointing to, that's all artifact. That's where I was telling you breasts have a lot of water. They get a lot of artifact. The new generation probes actually reduce that artifact significantly, and that's what's coming out with the machines. But initially, and what we still do is the engineers were able to take the total hemoglobin and the relative amounts of each, deoxy and deoxy, and create something like a subtraction mask. Think of it as like CAD on MRI when you do CAD stream or something like that. They could create a subtraction mask to give you the combined and reduce the amount of artifact a ton. And that's why I said that mostly you're going to use this 1, 2, and 4, these three in the corner right up over here, the upper left-hand corner or the left-hand corner up here. And those are the three that you'll do most of your reading on. And we thought, well, do we really need to keep these other three on there? And a lot of the readers in the research protocol said, yeah, we want to see the data. We want to get to understand it better. And so that's why it's initially. But you're going to use the grayscale, the total, and the combined most of the time when you read, and you're looking at, again, not only internal features, but boundary zone features and peripheral zone features. How are these blood vessels approaching the mass? And this, again, the blush over here and probably some whiskers over here are because of the resolution of OA having to combine, having to volume average a lot of the voxels. Okay. Same thing over here. Total blood over here and total hemoglobin, whether it's oxy or deoxy. But again, it's giving you, it'll give you morphologic evaluation of the blood vessels. Not only how are they coming into the mass, but are they smooth? Are they nodular? Is it a tangled mess, or is it something smooth? Again, over here, and it'll also give you the functional information with the oxy and deoxy. So another benign case over here. This was the mammogram. This was from one of our sites in Europe. This is the ultrasound features over here. And when we engage this, initially everybody, and they biopsied everything. We have biopsy proof on every one of these, or we've got follow-up if it was a BI-RADS 3. But in Europe, they biopsy everything anyway. Before they did the biopsy, though, they engaged the OA and they said, you know what? This, despite the appearance on the mammogram and despite the appearance on the sonogram, incidental baseline finding, this should be a fibroadenoma. And indeed, it turned out to be a fibroadenoma. Dense breast tissue, little palpable mass over here. And again, OA activity, I showed you this at the beginning, is predominantly oxyhemoglobin. There's nothing aggressive really about the way this is being approached by the blood vessels. And that's a dominant source over there. That's some of the artifacts that you'll see, but this blood vessel just coming in as a big feeding artery, draining vein bundle, and is nothing aggressive about any of the OA features. And it turned out to be a fibroadenoma. Same thing here, just because it's red, so it's a draining vein, maybe it's coming over an oval mass. Morphologically, it looks okay. Functionally, it looks okay. Predominantly green. Again, this is all oxyhemoglobin with nothing aggressive about the boundary zone or the peripheral zone. And so the concepts to keep in mind, though, are that it's not just internal findings. And I read in Seattle, I don't have an OA machine. I have ultrasound. But I look at my ultrasounds now completely differently, having read all these OA cases, because I learn about the boundary zone, the peripheral zone, and I want to see how this lump is interacting with the surrounding tissue. So now I tend to read from the outside in when I read conventional ultrasound, and I think that's a good way to do it. In my case, I go right to the boundary zone, and then I go to the peripheral zone, and then I come back into the boundary zone and then back into the central tumor nidus, because there's so much more information in the external part of these. Now, I talked about, I'm sorry. Yeah. So remember, there's functional findings with the OA, and there's more morphological findings with both the conventional OA and with both the conventional ultrasound and with the OA. And the findings can be internal and external and peritumoral. And in my mind, the most important parts are the external findings over the internal findings. So what studies were done to get FDA approval? A bunch of studies. Starting in October, I started working with Seno, I think around 2009 or 10, but multiple studies were done to validate the technology and to submit to the FDA for the PMA and to ultimately get FDA approval. All right. Some of these studies, like the Pioneer study, were 16 sites in the United States. It was a multi-center United States trial. Okay. Then the Maestro trial was a European trial, 5 sites in Europe. Submitted initially our packet to the FDA back here in 2016. And they said, well, we need a little bit more information. So in 2018 and 2019, had to do a couple of more small studies. And that ultimately, and publications, both gray journal and yellow journal publications to validate the technology, radiology and AJR, and finally approved by the FDA January 11th, 2011, not too long ago, a couple months ago. Now, the other thing, though, remember, I talked about these reference keys and I talked about the scoring system 0 to 6, 0 to 5. And I said, I don't want to get into the weeds because Seno has also developed AI that will do that for you. Okay. You take a lot of components that you're analyzing on the morphological scale and on the functional scale. And you can use machine learning and AI to assist in predicting the likelihood of malignancy. So remember, these reference keys I was telling you about have feature scoring from 0 to 5 or 0 to 6 in a couple of cases. All right. What if you had an AI box where you could put in 14 different inputs, including general mammographic features, general ultrasound features, the age, the depth, and then you can have, again, the ultrasound feature scores and the OA feature scores. Put all of these into a box, and in 14 different inputs, you get out one output that gives you the likelihood of malignancy. And let's say that this output that gives you the likelihood of a malignancy has numbers associated with it. And every time the number was maybe 3 or less, it never turned out to be cancer in all of these thousands and thousands of studies that we did, cases that we did. So, after a while, you would be able to adopt the technology. And as you understand it better, and as you go through more and more training, remember, this is an introductory course, an introductory lecture, introduce you to the technology. You would begin to, I know I can use it. To me, it's really fantastic. If I had one here, put one in for free, I'll use it, man. But anyway, it's slick technology. It really works. It delivers functional imaging and structural imaging about a breast mass. It's in real time, doesn't require IV contrast or ionizing radiation. And it, from the studies that have been shown so far, seems to be able to increase specificity significantly without impacting sensitivity. So that's pretty good. The big thing when you're getting used to this technology, I think it was really helpful to subcategorize the BI-RADS 4s. And that's hard to do for a lot of people because there's nothing really objective in 4A, 4B, and 4C. A lot of it is subjective. But if you really have an idea of why you're putting something in 3 versus a 4A, especially, your pretest probability will help predict your post-test accuracy. And I think it's going to be really helpful in the 3s and 4As. And there's even several low 4Bs at maybe 12, 13, 14%, in that category that can be downgraded. Future directions, I think it's going to, neoadjuvant chemotherapy after how many doses, we do a couple of rounds and maybe three months later, we'll repeat the ultrasound mammogram or the MRI, see if the chemotherapy agent is working. What if Opto-Acoustics after the first, a week after the first dose changes the blood maps so that you can tell whether the neoadjuvant chemotherapy is working within a week or two, as opposed to 3 months. I think that we're investigating that, but I think that's going to be something that has a really good chance of panning out. Thyroid, we've already, it's already a small parts transducer in terms of superficial. Thyroid superficial. We've got the transducer for superficial imaging. And how many thyroid biopsies do we do that turn out to be benign, that we could maybe get OA information on? And then prostate, it is so exquisite at picking up a small cancer, 3-5 millimeter cancers, and it shows them to you in such an exquisite way. You go out and read 250, 500 of these studies. Cancer, if they can get the electronics pushed down into a prostate biopsy probe, like an IVT prostate biopsy probe, this will be in every urologist's office in a year, because it'll show them how many times they have to pepper the prostate 18 times, random biopsies. Sometimes the man has to go through 2 or 3 rounds of a prostate biopsy over a course of a few months before he gets the diagnosis of prostate cancer. This will tell the urologist immediately, I think, where the money shots are. Right there. You want to do the biopsy right in that spot, and that's where you're going to get your prostate cancer diagnosis. So anyway, and then I was at OA I was at Seno a couple of years ago, and one of the techs there, Mike, his name was too, he said, "Hey, Dr. Yu, can you do a biopsy using OA?" And I said, "Well, I don't know. Let's find out." So we got one of the Phantoms, and this is an 18 gauge needle, and I want you to just watch the needle going through here. Now, watch it on the regular. Remember, when you do a biopsy and when you do anything in needle-wise in the breast, if the transducer is parallel to the needle, you see the needle really well. But as you angle the needle up and up and up, you get those deeper and deeper lesions. Watch when I angle the needle up. I'm going to angle it up here in just a second. Okay. Let's get the needle. Okay, there you go. Now, as you angle it up, it disappears from the regular, but look at the OA. You can still exquisitely see it on the OA. And I was like, hey, wow, that's pretty cool. Let me go up higher. And I go up higher, and it's still, the OA is, and then I come back down. Watch, I'll come back down parallel, and you watch here, it pops right back in on regular conventional ultrasound. And it actually looks better on OA angle than it does parallel. But anyway, so I thought that was pretty cool. And that's really about it. I'll be able to take some questions here in just a minute. In my free time in Sedona, I'm a volunteer astronomer up at the Lowell Observatory. I help run their telescopes, and I have some really nice telescopes at home. This is the Great Orion Nebula and the Andromeda Galaxy, and those I took with my own astrophotography camera. That's it. Thank you very much. And let's see,
Yeah, so Mike, I think we have run a little bit over on our time. So in the interest of time, I just wanted to thank you so much for just a great talk on optoacoustics. And I would encourage anybody, if you do have any specific questions, to stop by the Seno booth. I will be there all day, and I'll be available to chat with you, video chat with you, answer any questions that you might have. But Mike and I and all the folks at Seno, thank you for sharing with us your morning, before conference start. And hopefully this was informative for you and gave you more information about this exciting new technology.
Yeah, and let me say, Tammy, if anybody does stop by, feel free to share my email, cell phone with anybody, and yeah, I'll be happy to answer questions too as well. So I'm sorry I ran over. I was, but anyway, that's it. Good. Thank you.